last section of our conversation, we're going to explore how we deepen both our understanding and our ability to advocate for the right for health and as a tool to tackle discrimination and racism in healthcare. So we're going to continue with our approach using Slido. So I've actually got a Slido question I'd like to ask you, because our next speaker is Rachel Hammond, who's a senior advisor for the WHO Geneva Department of Gender Equality, Human Rights and Health Equity, particularly on diversity, equity and inclusion. Before she starts, maybe we could help her, because what do you expect from the World Health Organization to tackle racism and discrimination in health? So we heard earlier about the many treaties that exist, the special comments, recommendations that are being given to member states, the methodology that's being given. So now we're focusing particularly the WHO with its technical leadership and expertise, its unique role in advising governments. What do we expect the WHO to do to help in this process of tackling racism and discrimination? So resources, thank you. And whoever's put that, maybe we could think, is it financial resources, technical resources, monitoring resources? Is it the kind of research that we heard at the beginning of the day where you saw all of those peer-reviewed papers that have identified it? We've heard there's an increasing body of evidence. So maybe some of the challenge is turning that evidence into active policy. So monitoring and evaluation, setting the framework. Thank you. Remember, I mean, the World Health Organization is both the institution, but you have the World Health Assembly every year where all the member states come together. You have regional committees. There are many tools within the WHO portfolio. So what else could the WHO do to assist? So these are things that we're going to invite you to reflect on. And these are things that Rachel will then be able to either respond and say, that's great, we do it, or, oh, that's interesting, or that's not really what we can do. So this is the idea, is just kick off our conversation by understanding from you what you think the WHO could or should do. So here we've got co-design multi-stakeholder, implementing existing frameworks, swift in evidence hierarchy, okay? Political voice and advocacy. So thank you. This is really helpful. Where you see the WHO role, remember the WHO is part of the UN family, so it's interlinkages with some of the other agencies from Amelia's team and others. So where is the WHO's added value, its expertise? How can it be of use in the process? Visibility and guidelines, excellent. So maybe what we'll do is, Rachel, I'll invite you to start, and we'll sort of keep an eye on this and keep bringing up the Slido so you'll be able to respond to it as it happens. But initially, this is what people are thinking of. So Rachel, the floor is yours.
Thank you very much. And thank you very much for inviting me here to be with you and to deliver a few comments. And what I'm hoping is to keep my comments short so that we can have a dialogue, so that we can better understand all of the different roles that everybody around in this room needs to play so that we can deliver on what is health for all. So I'm really happy to see these different ideas of what WHO can do. As you can see, I'm an older person, so I've come to WHO later in my career with a lot of, I think I'm always a naive optimist about what WHO can do. I'm trained as a human rights lawyer, so I spent a lot of time working on health and human rights in my career, moved to Belgium and decided that I needed to do more public health work and went and did a PhD in public health at the VUB in Brussels while working at the Institute of Tropical Medicine. So I've come into contact with the biomedical community a lot, doctors, public health practitioners, seen that there's a real disconnect from those of us who work on health from a human rights perspective and those who work on health from a biomedical perspective. So now I take you to where I'm working in this department of gender, human rights, and health equity. And I hesitate because when I started a year ago, we were gender, equity, and human rights. Then we added a dash of diversity, equity, inclusion. And that's an important point because WHO itself recognized that our workforce, the WHO health workforce, doesn't have enough diversity, that there is not equity and there's not sufficient inclusion. And they decided to add that to this department, that they're not too sure what its initials should be, but they've got us all in there, and we're supposed to be mainstreaming gender, human rights, and health equity. So as I said, I'm a lawyer, so I take things from a human rights perspective, and I believe that health equity, social justice, and rights, they're sort of coterminous. They're different ways in which we try to deliver on health for all, which will look different for all of us because we're all different people. So to this first question of how does WHO engage? First, I'd say, why does it engage? Give you the very legal answer that it's in our constitution, that everybody has the right to health. We are the UN agency that delivers the right to health for all, not health rights, which as a lawyer, we always say, oh, well, health rights are a little bit different from right to health. But we know from what we heard from our OHCHR colleagues and others that there are many different ways in which the right to health is delivered. We need all of the rights that are related to health to be available for everybody, accessible to everybody. Otherwise, we don't get to the right to health. So the importance of this interconnected nature of all rights, civil, political, economic, social, and cultural, if we want to deliver on something as simple as health. So we all know here that health is a very complex issue, so it implies the realization of all of these rights. WHO works at 3 levels. So I'm currently based in Geneva. That's the headquarters of WHO, where Dr. Tedros sits, where we set the different guidelines at global level for all of our member states to hopefully implement. But we're a member state-led organization. And so we can set these guidelines, but we can't enforce that member states do this. So we can make these recommendations, evidence-based recommendations, lots of peer-reviewed publications being looked at and examined, but the implementation challenge is a huge one for WHO. So there we look to down to the 2nd and 3rd level. So headquarters, regional levels and regional committees, they work with the member states. And I learned very soon into my time at WHO that we don't jump from headquarters to country offices, that we need to go through the regions. So in Europe, we go through WHO Europe in Copenhagen and all of the related offices if we want to work with European states. We're allowed to work directly with them as long as our regional office is happy. But for us to be able to deliver on the accountability, we're looking more down to the regional offices to help work with the member states. So let me give you an example of how we deliver on at HQ level. We have resolutions set. So if we're thinking about discrimination and racism in healthcare, we have a recent resolution at the World Health Assembly on Indigenous peoples and Indigenous peoples' health, resolution 76.16 passed last May, which requires our global level office develops a global plan of action to be able to advance the health of Indigenous peoples across the world. So we need to consult with our regions and countries to understand what different health challenges the Indigenous peoples of different countries have. I grew up in Canada. Canada has finally recognized the United Nations Declaration on the Rights of Indigenous Peoples. So taking a non-individualistic approach to human rights and a more collective approach, which is the way in which Indigenous peoples want their rights to be advanced and recognized, understand our own Indigenous health knowledge, and that it doesn't have to be forced into the biomedical Western conception of health. So that's one way in which WHO works on this, with member states, getting them to work together on a resolution that's proposed by a member state, and then working on the language, and then we help with developing a global plan of action to implement this. But again, we're not the implementers, we're not funding it. We're just trying to provide the normative framework that aligns with different commitments. So what counts as evidence for us? That's a little bit problematic for somebody like me, because a lot of our evidence has quite a biomedical bias. And increasingly, we're bringing in the social sciences and understanding of cultural diversity, the important things that we've been discussing here that allow us to be able to adapt guidance so that it can be relevant to the people who it's supposed to assist in realizing their health-related rights. And so how do we bring in people's voices? For me, one of the most interesting ways in which I found WHO works on this is something called our Patient Flagship Initiative. It's not exactly the language that, from a human rights perspective, I want to be using patients. I know from my disability colleagues that we want to be talking about service users, more service. But the idea, and it's also something that's very much coming out of the UK, is that as somebody who's using a health service, that you have a right to a second opinion, and that you have rights as a person when you go into a health setting, rights that need to be respected. And so this initiative is trying to develop a patient safety charter so that patients can be safe when they go to healthcare settings. And in the UK, recently, it's been quite a lot in the news because there was a young girl who died in a hospital, and the hospital was not allowing her parents to get a second opinion, even though they requested a second opinion. So to have this right as either a patient or the patient's guardian to have a second opinion is something that I think will be included in this patient safety charter. So that's listening to the voice of service users, experts by experience, and having that degree of humility, moving away from the biomedical model, which is not a very popular approach at WHO, because we're filled with doctors who spent years specializing in different things, getting their PhDs, etc. So to have that humility to listen to the voices of people who've been through a system and where there were problems or where the system fails them, that's something new and something I really applaud. And from a rights-based perspective, that's what we should be doing. I think I should also mention that at Euro level, I've done some work with different academics across Europe on how you can increase health equity in your health policies. And again, the voices of people with lived experience, particularly during COVID, informed a lot of what we did. The exclusion that people felt on multiple different levels needed to inform future policy making in this area. So we developed something, and it's a long name, How to Equity-Proof Your Policies and Interventions. It's a resource guide for planners and policymakers so that they leave no one behind. So you hear again the UN speak of leaving no one behind, the Sustainable Development Goals pledge coming in there, but trying to help policymakers to understand what this means at a practical level. So we've come up with checklists and other such things, but it needs to be used. And I'm hoping that working with policymakers and all different stakeholders, this provides one way in which we can do that, because we talk about the importance of social participation, what that means and why that improves inclusion in your policies. So those are global and then Euro level ways in which we do this. So at WHO itself, our department is supposed to be mainstreaming equity, human rights, and gender, using an intersectional lens for analysis. So working across the different departments that are, of course, somewhat siloed in the same way that we see in governments across the world. We separate ourselves up into physical health, mental health, non-communicable diseases, certain communicable diseases. We have sexual and reproductive health, and then we have maternal and child health. Not sure why we have both maternal and child health and sexual and reproductive health separately, but we do. Our task is to try and infiltrate all of those different departments with a human rights-based perspective, bringing in the 9 different treaties, so the Disability Treaty, Women's Treaty, etc., to the work and showing where it's relevant. We also work, of course, with the Office of the High Commissioner for Human Rights, and we work with something called the UN Interagency Task Force on Non-Communicable Diseases, which brings in UNICEF, the Food and Agriculture Organization, many other UN organizations, so that we get out even of our agency silos, just focusing on health as WHO, as if that's the only way that you can improve people's health. And the biggest thing that we need to work on, and you don't have there, is capacity building at country level. So here I just told you, I'm from headquarters. We're not supposed to work in countries unless the regions say that we can. We're pushing our regional colleagues to work on capacity building on human rights. So knowing that there are legally binding commitments that countries have made, ensuring that our WHO colleagues at country level can work with different ministries to be able to implement those. Otherwise, the human rights framework means nothing. If we're just working at country level on technical papers, implementing things in a technical way, if we don't understand how a human rights-based approach adds a really valuable tool to their toolbox and including everybody in a health system, we're not going to be able to get to this goal of leaving no one behind, being able to have universal health coverage. So the human rights-based approach from WHO really has to be rooted as it is in law. And I don't just say that because I'm a lawyer, but we know that the legal determinants of health, as we function in really law-based societies, a law-based system that, first of all, solidifies all of the underlying structural inequities at a global level. So that's already problematic in itself, that we have the rule of law, but we know that law is one of the big problems because we're cementing in place structures that perpetuate and exacerbate discrimination, racism, etc. How do we balance that? This is where the human rights-based approach is supposed to be different, because it's asking that law doesn't just reflect power structures, that it challenges those power structures by bringing in the voices of people who we say are from below. So localizing human rights really means that we bring in the voices of different communities, service users, so that we can ensure that those power structures are challenged. We heard earlier today from Samira, the MEP, about the importance of legislation and the need to implement. But we can have legislation that cements power structures, inequities, and exclusion, or we can have legislation that has been informed by inclusive processes and therefore doesn't do that. So this is why a human rights-based approach and implementing it actually should, in theory, and does make a difference. We heard from Abby that racism kills. She repeated that several times, and I think that's a really important message for all of us here, if we didn't think about it before, to know that it can kill quickly, as it does for Black women in the United States, the UK, Canada. When we look at the statistics of deaths, preventable deaths due to maternal mortality and morbidity, the exponentially higher rates, that's a quick, horrible death. But it also kills slowly, we heard from her, about these allostatic levels and the way in which the stress of living with racism on a daily basis contributes to lower life expectancy and gets passed on from generation to generation. So we have that imperative to address this, and law is one of those tools for doing it. And I just want to finish off and give you a more practical example of how we work with law to try to increase access to health prevention, promotion, and treatment. And I want to look at vaccines. because that's been something that has been on a lot of our minds because of COVID. But we've also, in some ways, probably not the people in this room, but we've taken our eye off the ball when looking at things like childhood immunizations. And the importance of this is a great public health advance that we have managed globally to roll out childhood vaccinations and lower preventable under 5 mortality. So when we take a rights-based approach to looking at this, we look at the barriers to equal, substantively equal, or if you want to call it equity, health equity. And we look at what barriers exist within countries and between countries. So we all know globally the COVID example showed us global health inequity at its most raw in terms of the vaccine rollout, the way in which law was used to prevent different countries from either developing ways of producing mRNA vaccines and also rolling them out. So we've seen global health inequity on that scale. But what has really shocked me is to hear that in 2022, there were over 21 million children who missed their first dose of the measles vaccine. This would be in lower income countries. And that globally, there are over 14.3 million children who are 0-dose children. This is because of the massive health systems and supply chain disruptions, not related to anything to do with intellectual property rights, but just all of these disruptions through the system, and who gets most affected? What's going to be children in low income settings globally. That's veering a little bit away from Europe here. So COVID highlighted this inequity. So at country level, we know that access to vaccines can be increased if we address all of the different barriers, including social exclusion, discrimination in healthcare settings, the geographical disparities between rural and remote areas and urban settings, language barriers, legal barriers like migration status that prevent people from getting access, and also gender-related barriers to health. This includes men as well, men who have much less help-seeking behavior in most cases than women. So finally, I'm just going to conclude with what do we try to encourage from a rights-based perspective? Well, implementation of these rights-based norms, understanding things from an intersectional perspective, that we also need an intersectoral approach, that health doesn't just come from the health sector, that addressing the structural and institutional drivers of health inequity requires that we look outside and engage outside the health sector. That community-based service delivery, for example, with vaccines, having flexible hours and targeting the populations that are most in need by speaking to people from the different communities that are excluded to understand how we can overcome that barrier. We're talking about women who are bringing children to get childhood vaccines, and you need to ensure that there are ways in which women are enabled to be able to bring their children. So maybe you bring the vaccines to them rather than having them going to the medical centers and waiting. Information and education, especially with respect to vaccine hesitancy and uptake, engaging with the communities to build trust, because WHO has lost a lot of trust globally. Vaccines have suffered. Immunization has suffered because of the mistrust related to the COVID vaccine. Who would have imagined? But this mistrust has sort of percolated downwards, and people are afraid to have their children vaccinated. If you live in a society where you're marginalized, are you really going to believe the powerful who excluded you from being able to access things or kept you locked up and unable, if you had a precarious job, to be able to go out? And finally, I want to mention this importance of data collection. The disaggregated data, encouraging countries to do this. WHO tries to work on this. I know the Bill and Melinda Gates Foundation also works on collecting data. You can all ask a lot of questions about their engagement, in global health, but this Institute for Health Metrics and Evaluation has been able to collect a lot of necessary data. Why isn't WHO doing it? Well, I'm going to look to one of the words that appeared here at the beginning, which was resources. We don't have resources. WHO is pretty chronically underfunded. So who jumped in? The Bill and Melinda Gates Foundation, and that's who's providing some of the disaggregated data. So countries need to get better at being able to fund their statistics offices so that we can get non-biased data. Maybe the Bill and Melinda Gates data isn't biased, but it's a longer conversation for us to have. So I'm going to stop here, and I think we're going to have a longer conversation now. Thank you.
Thank you very much. Lots of food for thought for your input. And again, we'll share with you the results of that slide of what people are expecting from the WHO. So please take a seat. And I'm going to invite to come and join me